All right, everybody, we'll go ahead and start our next session. So I have the great honor of introducing Dr. Nina Shapiro. She is the professor of head and neck surgery at the David Geffen School of Medicine and the director of Pediatric Otolaryngology and professor of head and neck surgery, like I said, at UCLA. She's one of America's leading physicians and is a sought-after media consultant to set the record straight about the latest health fads and misconceptions. Please welcome Dr. Shapiro as she discusses the road to pediatric otolaryngology. Dr. Shapiro, you are welcome to share your screen and your video. I will stop sharing. Thank you so much for joining us today.
It is so great to be here. Thank you so much for having me. Let me share my screen if I could do this. I have learned so much technology in the last 5 months. It's amazing.
Of course.
How's that? Did that work?
That's perfect. Thank you.
Great. All right. Well, thanks again for having me. This is a great conference. And today I'm going to be talking about the road to pediatric otolaryngology, which definitely does not need to be a straight path, as you shall see. So how did I get there? And I know you've already had a lot of discussions about medical school and probably some residency questions. And I heard, there were some MD, PhD questions. So just very briefly, typically it's 4 years of university, undergraduate college, 4 years of medical school. There are some places that still have combined programs where you can do a 6 or a 7 year program, but typically it's 8 years after high school. And then the residency programs are traditionally 1 to 2 years of general surgery, which is, as it would sound, just really doing all types of surgery for 1 or 2 years. And then the residency program is a standard of 4 years of otolaryngology residency. So after that, there is what's called a fellowship, which is usually 1 to 2 years of sub-specialization. So after you're trained in otolaryngology, also known as ear, nose, and throat surgery, you go on to do 1 to 2 years of sub-specialization in pediatric otolaryngology. Then you take a breath and then you're done. And then you get to start your life. So really life begins after training. I always tell people that, don't choose a specialty by the training, to choose a specialty by what goes on after you train. So why would someone want to do what I do, or even what ear, nose, and throat surgeons do? So to do what I do, you have to like or love being in the operating room. So if you don't, it's probably not the field for you. You also have to love, or at least like, seeing patients in the clinic. And, for those of you who are thinking about going into medicine, to many of you, that seems obvious. Of course, you're going to want to see patients in the clinic, but a lot of people choose medicine not to see patients, if they want to do something that's not necessarily direct patient care, but be in medicine, that's still a possibility. But for our specialty, we spend about 60 to 70% of our time seeing patients in the clinic or in the office. So you do have to like that as well. It's a very interesting area from an anatomy and pathology standpoint. So you do have to love that area, the interesting anatomy of the ears, the inner ear, the middle ear, the airway. You have to really like that to want to go into the field. And then we have a lot of technology and a lot of techniques, and that evolves really every year. Now we're using a lot of robot. It's a lot of, other sorts of scopes and lasers, and, we call them toys. So, whether it's in the office or in the operating room. So that's something that helps if you enjoy that as well, if you like to use your hands. But a lot of the stuff that we do is almost like virtual reality. So it's not necessarily digging into the patients literally. And then even though it seems like a really, really focused area, there's a huge variety of patients and a huge variety of disease entities that we see, even within pediatric ear, nose, and throat or otolaryngology. So it's really nice that we have that variety. So what is it? It is a surgical field. So there's no such thing as a medical ENT or a surgical ENT. We are all surgeons. So it is a surgical field, but there is a lot of medicine in it. So it's not as purely surgical as something like trauma surgery or general surgery or even neurosurgery. We do a lot of medical intervention as well. We have a mix of short-term and long-term care of patients. So sometimes I'll see a patient once or twice, and never see them again, which is great. And sometimes I'll see them because I do kids for their entire childhood, literally from when they leave the hospital or even while they're in the hospital as a newborn until adulthood. We get to work, and one of the best things about our specialty is that we get to work with other specialties. And it's really, I always say that medicine is really a team sport. So we get to work with radiologists, plastic surgeons, dermatologists, neurosurgeons, pediatricians, anesthesiologists. That's just part of the list. It's really nice that we don't really just work in this bubble of ourselves. We work together with other specialists on a daily basis. And then, again, I mentioned before, there are a lot of new toys in our field. So that's always fun, because if you have a certain way of doing something in your practice and then a new gizmo or a new technology comes about, it's always fun to try something new. So I'm going to talk a little bit about women in medicine, because I think this is really important, to remember, because it really hasn't been that long. So the first woman physician in this country was in 1849, and that was, there were really just a handful at that time. About 40 years later, about 10% of physicians were women. In the early 1900s, the American Medical Women's Association came to be. In 1945, so around World War II, Harvard Medical School admitted the first women. Title IX, for those of you who are in college or do any sort of college sports, that came to be in the 70s. In 2000, still only 25% of physicians were women. So you jump over 100 years and it's gone from 10% to 25%. So really not a big jump in those first 100 years that women were physicians. A year later, close to half of the medical school applicants were women. So then you're going to start to see a lag, but you're going to start to see some increased numbers as the years go after that. This hashtag, I look like a surgeon, came about in 2017, sort of along with the Me Too movement, just to demonstrate that there's no certain look that a surgeon should have, whether it's by gender or anything else. So that's became popular just a few years ago. And now, just a few years after that, about half of the surgery residents, and by that we mean all surgical fields, are female. So in another 5 to 10 years, we'll start to see the other numbers as far as people who have been out in practice increase as well. So what about women in surgery? About half of medical school graduates, and in some places it's actually more than half of medical school graduates, are female. And about 15 to 20% of surgical training programs were women before just a few years ago. And by, sort of translating that down the line, about 20 to 30% of surgical faculty, so, medical school faculty, whether it's professors or clinicians, are women. So that number is continuing to increase every year, but obviously it's very slow. So with all of those numbers, are we happy? Is this really what we wanted to do as women? So what is the career satisfaction? And some of these pieces of information I'm giving you were from several years ago, studies done about 5 or 10 years ago, or even a little bit longer. Why do women choose surgery? It's a hands-on specialty, so you do need to like to work with your hands to be a surgeon, or I highly recommend it. It's challenging, so people want to take on the challenge. And something about being a surgeon is the notion of immediate results. I want, this is broken, I want to fix it. So there's that satisfaction that we get from fixing something with immediate results as opposed to longer term results from some of the other specialties. So why don't women choose to be surgeons? Or really, why doesn't anyone choose to be a surgeon? There's the notion of the residency lifestyle. So you hear that idea that residents work too hard, they don't have enough free time, they don't sleep enough. That has changed substantially over the last 5 or 10 years. There are laws now that residents can only work a maximum number of hours per week. They can only work a maximum number of hours in a given 24-hour period. They have to have breaks, and this is by law. So this has improved residency lifestyle across all specialties dramatically. Practice lifestyle, that's another story. There are no laws as far as saying how much or how little we have to work. So nobody will tell a doctor out in practice that they need some rest, unfortunately. That has to be self-regulated. But there's a concern that a surgical lifestyle is hard. And then another thing, and I really, really discourage anybody from considering this as a factor, is length of training. because the training is something that you will do, whether it's 2 years, well, really nothing is 2 years, but 3 years at the very minimum to 7 or 8 years higher up. In the more complex specialties, that should not be a reason not to choose a field, because you have your whole life ahead of you, and you don't want to cut the training by a year or two just to get through and then not be happy with your decision. So what are some of the negative impacts? Most of this is nothing new. Sex discrimination from male attendings and residents. Obviously, there has been much improvement there, but it still exists. Residency life, it's hard to be a resident. It doesn't matter what you do as far as your specialty. It is hard to be a resident. It's a lot of fun. It's very satisfying. You make some of the best friends you'll ever make. But it's a hard few years. Again, that's across all specialties. You're not going to be a doctor to become a resident. That's something that everyone gets through in order to do what they love to do. There is some perception of a surgical personality. We're a little bit brash sometimes, but that's the way it is. And there's still the perception of the old boys club, certainly some parts of the country more than others, but that still does exist. So what are the positive impacts? So obviously we have to look at the good side. And really, if you have a good experience with a mentor, you will be more likely to choose that field. So if you work with women and they seem happy, which is interesting, they don't necessarily have to be happy, but if they seem happy in their life, you may be more likely to choose to be doing what they do. So if you perceive that whoever you're working with or your mentors, regardless of their field, are unhappy, then for good reason, you're unlikely to choose what they do for a career. So men and women are equally satisfied, but for different reasons. Again, this is a bit of an old study. Men are looking more at training and compensation. Women are considered more focused on support networks and professional growth. There's an interesting perception bias in gender. So if you ask men if they think that surgery is a good field for women, 4.8 out of 7 will say yes. If you ask women the same question, 6 out of 7 will say yes. So role modeling is really crucial for success in whatever you choose to do. Find somebody who you connect with, who connects with you, who you can look at and say, this is something that I would be interested in doing. Their life seems interesting. Their career seems interesting. If you don't have that, it's really hard to find something that you will enjoy. So what's important? It is important to have a work-life balance, regardless of what you do, what medicine or elsewise, otherwise. Time predictability is really important, and controllable time predictability is really important. You lose a little bit of that during training, although again, that's gotten a lot better. You have to have a life outside of medicine, or it's really unhealthy. So you want to have time for friendships, relationships, social support networks. That is really important, not only for your emotional and social success and happiness, but also for your professional success and happiness. So women in otolaryngology, we have this is a very tiny specialty. So the numbers are, different when you're compared to when you're looking at physicians as a whole. It's a very, very small. There are about 200 new otolaryngologists in the country per year. So it's a very, very small group of people. And there are, there are more and more women over the years, but again, we're still a pretty small group. So less than 10% of residents were female in the 80s, went up to 15%, and then around 20% about 20 years ago. And in the early 2000s, about a quarter of the otolaryngologists were female. It was less than 1% in the 60s. And now this is a 35%. Some programs, in my program included, we have more than 50% of our incoming residents are female. So the numbers are starting to shift slightly, that it's going to become over time probably closer to 50-50 female to male in our specialty. So the glass ceiling, you've probably heard that expression before. It's really just a question of leadership. Are there leaders in our field that are female? And the answer is yes. About 15 years ago, the first woman president of our academy, the American Academy of Otolaryngology, the first woman surgical chief at Johns Hopkins. Johns Hopkins is sort of considered the surgical mecca in many people's eyes. And so the first woman surgical chief was in 2005. And then the first woman chair of an otolaryngology department was a year later. There's been an increase in female productivity and publication over the last decades. But again, you can see the numbers from 4% to 8%. While it's doubled, those are still both some pretty low numbers. Now about 5% of department chairs are female. So I think there are about 50 departments. So it's a pretty small number as far as leadership positions that are female in our field. So what's the problem? It all sounds great. Overall, job satisfaction for females is lower than in males. There is a tendency to reduce work hours after children, and there are more responsibilities at home. And again, this is across the board for any profession. This is changing, obviously, gradually as the years go by, but this is still the case in our specialty. There has been a change in culture in surgery as well as medicine, where the hours are more flexible, allowing for more family time. And again, that's both for men and women. It shouldn't be just for women. I think men also need to have that sense of flexibility to spend time with family. So you can do it. I really think that, it's very easy to get discouraged when you hear about these sort of daunting fields ahead of you, and that there's really, something that you have to overcome. But this field especially is an evolving field. It's for men and women. It's not really a male. There really are no male fields or female fields in medicine anymore, although a lot of the stigma still applies. Residency work hours are reduced. So I really, really encourage you, if you're considering a specialty, do not focus on the residency issue, because it's really the playing field has become very equalized, and it is really, you will have a life outside of residency and after residency too. So flexible schedules have increased. And there is no one way to be any sort of specialty. So there is, I talk about these varying levels of busyness, and you don't want to get caught up in having to be the busiest. It doesn't necessarily mean that you're the happiest or the best. So the levels are endless. And I personally, I don't think a surgical personality is so bad. We tend to be very sort of goal oriented and, fix the problem oriented. And, we do have to act quickly, certainly when there's an emergency. But I think it actually makes for some interesting personalities. So what's my schedule? This is just a rough idea. This is not, literally my schedule, but this is roughly my schedule, just to show you that, and I've been in practice for a few decades, but again, it's been similar to this for many years, where I really do try to establish some semblance of balance in my life. So as you will see from these slides, I like to run. So there's a lot of running on my slides. So on Mondays, I run early in the morning. I try to take my kids to school or the bus. And then I go to clinic, so I see patients in the office, and then I return phone calls and do all the other things like this talk or any other sort of academic work that I have. My kids are a little bit older now, but if it's early enough, I try to pick them up from school or pick them up from their bus. And then it's just like everyone else in the world. There's dinner, homework, and everything else that goes along with life. I do take call for emergencies a few days a week. So there's always that chance that I can get called back into the hospital. And again, that's just a few days a week. Tuesdays, I go into the operating room at UCLA. So that's an early morning. I leave the house at about 6:20, 6:30. I am not a morning person. So I obviously wasn't thinking straight when I signed up for surgery, but it is something you get used to. And again, it is what it is. I could sleep late, but I get up early a couple days a week. I operate in the hospital, and then the home routine again, and then I take call. And so that just means that you get called in for emergencies depending on the level of where you are. If you're a resident, you may already be in the hospital. But if you are an attending and sort of you have residents who call you, and then you see whether or not you need to come in on an emergency basis. Wednesdays, very similar to Mondays. I do some academic work. I try to block off a little bit of time during the week to not have clinic and not have surgery. So that's a time to do paperwork, catch up on any academic work, go to the dentist, anything that I need to do with life. And then I see patients in the afternoon. Thursdays, I operate again in the surgery center. So I do outpatient surgeries, which means healthy kids who need, say, their tonsils out or their adenoids out or ear tubes. Same thing, I get up early in the morning. I do outpatient surgeries and then I come home. Fridays, similar to my clinic days, I see patients, I go to my kids' schools if I can. There's always some paperwork in really, again, in any profession that you have. So I try to do that during the sort of downtime in clinic, if there is such a thing, and then home routine. So what about the weekends? Well, it depends. That's, I like to have that time for family and any other sort of projects I'm working on, but family really does come first. But occasionally I'm on call and occasionally there are emergencies. And so, that's again, with any field that you will be doing. So, if I am on call, obviously I'm not going to be leaving town. So sometimes that makes some people upset. This was an old picture in my kitchen many years ago, one of my kids. So, obviously I'm never late for the OR. I'm always there, but it is, sometimes a little bit of a balance, especially on the weekends. So I do try to do some fun stuff with my family. Again, this is an old picture. So what do I see? So what is this specialty that we're talking about? So this is a child who you can look in her mouth and you can see that she's sticking out her tongue. She looks very happy and healthy. And those two big blobs in the back, those are her tonsils. So one tonsil here, one tonsil here. She was having what's called sleep apnea. She was having trouble breathing. So this child got her tonsils out. We also took out her adenoids, which is like a third set of tonsil tissue you can't see, but it sits up behind the palate there. So this would be an outpatient surgery or an inpatient surgery, depending on how severe her breathing problem is. And remove those tonsils and then the airway would be this big space right there. So her breathing would get much better. This is a child in the operating room, not having his tonsils out, but having vocal cord surgery. So you can see here, he's asleep. And this is what's called a laryngoscope. And this is an endotracheal tube, not in his airway. He's just getting some oxygen through this and breathing on his own. So he doesn't have a breathing tube. He's not on a ventilator, but he's completely asleep. And these are what vocal cords look like. So just some timely news, and this is public. Anthony Fauci had vocal cord surgery today for his hoarseness. So hopefully his vocal cords didn't look like this, because this child has something called papillomas. These are literally warts of the vocal cords caused by HPV. So hopefully for this generation receiving the HPV vaccine, their kids will not get HPV, because this is acquired from the amniotic fluid. So it's from the mother. So this is, of what we see of the vocal cords in a child with HPV. This is after the lesions have been removed. And this is his trachea or his windpipe, which looks completely normal. This is cartilage here, and then soft tissue in the back. And this wall connects to the esophagus. This is another thing that we see. This was an emergency. This child couldn't breathe, a tiny baby. And you can see, instead of seeing vocal cords, you see this blocked area here. This was a big cyst that grew very quickly. And the child presented, to the emergency room with trouble breathing. And when we looked, we saw that this cyst was blocking the airway. Beyond the cyst, this is the windpipe, which looked pretty good. A little bit of floppiness to the trachea here and down here, but not too bad. And then we opened up the cyst, put in a breathing tube. So this is what's called the epiglottis, that little leaf that opens and closes the voice box. This is the area where the cyst was, so it's now free. We did put it in a breathing tube temporarily, so the child can breathe during the surgery. And then we took the breathing tube out afterwards. So this would be an emergency that we would see. Another emergency, this is a child who had some breathing problems and a cough. And every time she coughed out this big mass here, and then she would breathe in, and it was on a little flap, this little attachment there. And she would breathe in and it would go down into her airway. She would cough and it would pop up. So she had this, what's called a granuloma. It wasn't a cancer, just a big mass around her vocal cords. These are her vocal cords, which look perfect. But then we removed this mass and her cough went away. So how do you decide when you're thinking about all these different fields? There is something about a surgical personality. Again, we do, like to take care of emergencies. We do see some airway emergencies and, bleeding emergencies and other sorts of emergencies. It's not that common in our field, but we do see them occasionally. There is something to be said about a surgical culture. It is not male or female. It is just the way it is. Again, we tend to act quickly. We do have to have a little bit of impulse reaction when something is an emergency. We don't use, oftentimes we don't have the luxury to think about things when there is an emergency situation. And again, I've mentioned this, but I'll mention it again. Look at your attendings. When you're in medical school and you're thinking about specialties, the residents will be the ones you spend the most time with. They're closest to your age. They'll probably be just a few years older than you and having just finished medical school. But you are not choosing your specialty to become a resident. You're choosing to become a physician and attending after residency. So really see how your attendings are. Are they happy? Are they sad? Do they seem to enjoy what they do? Are they miserable? Are they interested? Are they helpful? So really look at that. And so look ahead. And every year does get better. Internship is a tough year, but again, even that has gotten easier and much more sort of civilized over the last few years. And you can make it work. There is no right situation or best situation. There's no best time or worst time to do this. And things have gotten so much more flexible over the last few years that you really can make it work. The possibilities are endless. You can do clinical work where all you do is see patients and operate, and you don't do any research, and you don't do any administrative work, and you don't do any teaching, but you just love seeing patients and love operating, and that's great. You can do fully research work where you never see a patient and all you do is research and you love that, and that's great. You can do a mix of both, and there's no exact percent. You can do 80%, 20%, 90%, 10%. Nobody is deciding this except for you. And the other thing to remember is that whatever you decide can change. So if you go into a specialty and love clinical work and then realize you don't love clinical work, then you change. It really has to be all about what's going to make you happy and fulfilled and satisfied and do good work. Or if there's something else. So again, things have expanded even more. You may be interested in administration, healthcare administration. That's a huge sort of area within all medical specialties. It's not necessarily one type of physician that chooses to go into administration. You may be interested in business endeavors. A lot of medical schools, or at least a few medical schools, have now MD, MBA programs. So if medical business is of interest to you, that's also something to pursue. And plenty of people go back to get their MBA after medical school while they're already in practice. So again, there's not just one straight line that you have to follow. Public health is really, really important. And a lot of people are combining that with their work. Global health. So traveling, if you are interested in helping people across the world and using your expertise all over the world, that's also a great option. Media and social media used to just be, oh, that's just for those few people that are, doctors on television. Now, obviously, it's really open to everybody. And I've, dipped my toe into that a little bit, as well as writing over the past several years, because I feel like that's another way to lend your voice to the world and, share your opinions or your interests, or even something that's a little bit of a side interest. So there are a lot of physicians who do a lot of media and social media and writing, and it's really become its own world that's really just continuing to grow. So with that, I did write a book a year or two ago called Hype, and this is not a book about ear, nose, and throat surgery. It's not really a specific book. It's really a general health book that, just over the years, hearing about patients' concerns, hearing about so much bad information that's received, because there really is no peer review on the internet, as you all know. So I wrote this book a year or two ago, just based on my interest in writing and speaking and, sharing information. So it just shows that your career can go in directions that you wouldn't necessarily even expect. It's the last thing I thought I would ever do when I went into this field. So this is some of my staff that I still work with at UCLA, and everybody's very happy. This is in the operating room, and in the recovery room, and a lot of these folks are still with me at UCLA, and we still have a great time. So yeah, you can do it. It's there is, the possibilities are endless. I really want people to feel open to anything. Don't ever think that you can't do something if it's something that you really want to do. And I am happy to take any questions.
Thank you so much, Dr. Shapiro, for your presentation. It was amazing. I learned so much.
Thanks.
I'm specifically interested in pursuing surgery, but I haven't really dipped my toes into it yet. So your presentation really gave me an insight into what a week is like for a surgery in your specialty. So thank you so much for that.
Sure.
If it's okay with you, could you stop sharing your screen?
Sure. Thank you. Yes.
All right, the audience should be able to see both of us now. All right, so we'll get started with some Q&A questions. Our first question is, how did you find out you wanted to be an ENT, specifically a pediatric ENT? What was your residency like?
That's a great question. So, while I was in medical school, I thought about a few different specialties. Actually, I really loved, and I still do love, ophthalmology. So that was something that I was really strongly considering. And then I spent some time in working with ophthalmologists and spent some time working with otolaryngologists. Full disclosure, my older brother is an otolaryngologist, so he was a resident while I was in medical school. So I had some sense of what he was going through. And then I also just spent time with the two different specialties, and I really connected with otolaryngology, mainly because, again, the attendings seemed to be having a really good time, and they had been out 20, 30, 35 years, and they were still loving what they do. So that really was very encouraging to me. I really enjoyed being in the operating room with them and spending time with them and seeing the problems that they were treating, and how satisfying the surgery was and how fun the surgery was. So I chose that. I did not think I was going into pediatric otolaryngology when I started my residency. So my residency was in Boston at Mass Eye Infirmary, where we rotate through not just the infirmary, but through many of the hospitals in Boston. And early on in my residency, we did a pediatric ENT rotation. And really, probably by the second or third week, I said, this is it. This is what I want to do for my life. And then I had 4.5 more years of not doing pediatric ENT before fellowship, but that's part of the training. And really, so it's really just based on experience. Again, I didn't go into otolaryngology thinking I was going to do pediatrics by any stretch, but it was a good choice.
Yeah, that is a wonderful response. I have a follow-up question to that. Was there any spark or one significant moment that made you realize that, yes, this is what I want to do with my life?
Yes. So as I said, when I was working in otolaryngology as a medical student, and I was working with an attending, again, he was probably the most senior attending and the nicest guy, really inspiring. Everything was great. He just had one of these up personalities. And he said, hey, and again, I was like a third-year medical student, and we were allowed to do a little bit, but really not much. And he said, hey, Nina, try this. And he helped me sort of hold this instrument to pull out something from somebody's nose. And he said, isn't that fun? Do you want to do that again? I said, yeah, that was actually fun. So it was really that moment that and again, I don't think it was the actual procedure that he let me help with. I think it was just the excitement that he shared that made it seem like, this is great, isn't it great? And I love it, and you're going to love it too. So it was really just the inspiration, I think, that was like that aha moment. And I think for pediatric ENT, it was just spending time with kids and spending time with their families and seeing their problems, and also seeing what we do these tiny surgeries in children, and they can be life-changing. Something called ear tubes, where you put this tiny little ear tube in a child. It takes about 90 seconds to do the procedure, but it changes their life in a matter of a minute or two. And to see that was really, really amazing.
Absolutely. Thank you so much.
Sure.
Our next question is, how do you balance your very busy schedule as a surgeon with your family obligation and your times with your family?
It's really hard. It's, I'm not going to say that everything is perfect. I think that, you kind of have to, there's also this expression of, can you have it all? Or, yes, you can, but not all at once. And, there'll be days where you get it and days that you don't. I think it's really important, ideally, that you have a good partner in your life, that is supportive. And, if they are a busy person too, that they understand what you're going through, and you understand what they're going through, and that you are together in it. I think that is really, really critical. You have to let go of any sort of guilt. I think that, the notion of having it all, I think that, if you want to be the busiest surgeon in the hospital, you're also not going to be, the parent who's on every sort of board of their kid's school and being at every event. There is give and take, and you just have to find, what works for you. So again, there, once you get out of sort of that school mode of, you're told where to go, you're told when your classes are, you're told when your assignments are due, when it's your decision, then there again, there's no right or wrong. You have to just make it work for yourself. And if something's not working, then you have the control to change it. So if you feel like you're overwhelmed at work and you're not spending time with your family, you have to let some of the work go. And you can.
Thank you. Thank you so much. Next question. What would you say the ratio is for outpatient surgery, inpatient surgery, and in the doctor's office practice of medicine that you do at your job?
So for me, it's about 50-50 inpatient surgery and outpatient surgery. So I do inpatient surgeries once a week and outpatient surgeries once a week. The difference is the inpatient surgeries tend to be much longer and more complicated and on sicker children. So if I do, let's say, 3 inpatient surgeries on my inpatient surgery day, I may do 10 outpatient surgeries on my outpatient surgery day because they're much quicker. But as far as the time goes, it's about half and half. That said, if you have a sick inpatient, it will take up a lot of your time and energy, because it's a sick child as opposed to a healthy child having an elective procedure. So it's about 50-50 time-wise. And then 3 days a week, I see patients. And that's each day that I see patients, it's a mix. Some patients are healthy, some patients are sick. So it's really just, I see all of the patients that have any issues, on those same days. I don't have like a sick patient day and a healthy patient day. It's all kind of mixed in.
Absolutely. Thank you.
Sure.
Next question. What are the main differences between pediatric otolaryngology and typical adult otolaryngology?
Right. So if you ask any pediatrician, they will tell you children are not just small adults. So a lot of the stuff is similar, but there are very specific issues that we see in pediatrics, primarily because we take care of a lot of airway issues. And so babies who are born with scar tissue in their windpipe, or breathing issues for other reasons, so what we call congenital problems. So issues that they are born with. So, the surgeries are very, very tiny. And, the patients are very, very tiny. Our instruments are tinier. And they see different problems. We don't see a lot of cancer in children. There are some head and neck cancers, but cancer of the head and neck is much more common in adults. Young adults now, unfortunately, but much more common in adults as opposed to kids. Sinus problems are a little more common in adults than kids. So we see a lot of the congenital stuff. So we see hearing loss, newborn hearing loss, cysts, so lumps and bumps that babies are born with, problems with their nasal passages. So a lot of things that we see are things that kids are born with. So we see a lot of kids in the NICU, or the neonatal intensive care unit, as opposed to the adults, where they see cancer patients with sinus problems, long-term hearing problems, things like that.
Thank you. Follow up to that question. Do you see a lot of children with those masses, lumps, and cysts in their vocal cords and in their trachea? And is that a common thing among children?
Okay, so no. So I do, because I work in a, I work in a referral center. So we, it's a different type of patient population. I'm not out in the community. We're working in a place where people, get flown in to UCLA because they have complex problems. So, for instance, that those pictures I showed with the warts on the vocal cords, there are about 2,000 new cases per year in this country. So, we're all thinking about numbers of COVID these days. So 2000, we have 2,000 new cases of COVID per day in Los Angeles County. So 2,000 new cases per year in this country is a relative, it's considered a rare disease. The issues with the breathing and the babies, we see primarily in premature babies. So babies who are extremely premature, meaning born at 28 weeks or 30 weeks or 26 weeks gestation. So really, really, really tiny babies who are ventilators. So, it's critically ill children. So, common, it's common in my practice, but, it's extremely rare. The little cysts that kids get, those are usually not, dangerous or life-threatening. We see them occasionally, a couple of weeks maybe, but it's not something that we see, an all day filled with babies with, lumps and bumps like that.
Thank you so much. It's very interesting. The next question is, what has been your most rewarding experience in your job?
Oh boy. It's really, I think that, some of I don't think there's one day or one event. I think one of the most rewarding things about my job, and I mentioned this before, is when we do something as a team. So we really, it's not working, it's not a solo kind of experience. So if we have a complicated patient and it requires very challenging anesthesia care and nursing care and assistant care and maybe another surgical subspecialty together, and we're working together on a very challenging situation, and the outcome is very happy, and everybody sees that the patient has done so well, those are really the most satisfying experiences that we've had.
Perfect. Thank you so much. I have a few more questions. As an author to the eye-opening novel Hype, as you discussed, what is your favorite myth debunked?
Oh boy. There's so many. Let's see. My favorite myth, I think, is has to do with supplements. I think that there's a notion of especially these days, about immune boosting, and how whether vitamins and supplements are really, really necessary and will protect you. And obviously there's certain times when we do need a supplement if you're vitamin deficient, but it's certainly in otherwise young healthy people, it's extremely unlikely that they'll have a vitamin deficiency or deficiency in a supplement. So the notion that taking them makes you healthier, I think, is a really interesting myth, because even doctors do that thinking that it's going to help them, but really deep down they know that it doesn't. So the fact that doctors are engaging in these health practices that are myths, with sort of this magical thinking, I find especially interesting.
Absolutely. Thank you for sharing that. I know I have experience with thinking about supplements as actually working and being right for me, but it seems more like a placebo. Not too sure, but healthy exercise and eating right and a lifestyle of balance is the way to go, as I've
Absolutely.
heard from doctors. Next, our last question, actually, before we wrap up our Q&A, how did you become a prominent speaker and advocate for healthcare in the media? I know you are very prominent in TV and also news articles as well, like NPR, CNN, BBC News, the Doctors TV. So if you could speak to how you got involved with that as a healthcare professional, that would be wonderful.
Yeah, it's a lot of fun. So I recommend it for anyone interested. There is no, I think that I just started writing a little bit. I think I submitted some op-eds. I started a blog. I got asked to do some, commentary on a few local news shows, and then it really just builds on itself. I think that especially if you have an area of focus or an area of passion, then you become the person, the go-to person. So, there are a lot of doctors who have, very specific areas that we see now, certainly again related to COVID, that, whether it's an emergency room physician or somebody really focused on PPE. So if you have a passion that's related to public health in any form, so mine has been vaccines, myth busting, child safety, food safety, choking risks, all those kind of things. If you really sort of find that niche that you are personally and professionally passionate about and want to share that outside of your specialty, then there are lots of, as you all know, I need not tell anyone younger than me about, the power of social media that really can create a platform for yourself. You just have to be careful, if you're going to be sort of navigating those waters, they're very deep. And, you just want to make sure that you do it safely and, protect yourself as well, actually.
All right. Thank you so much, Dr. Shapiro, for joining us today as our closing speaker of the National Health Conference Day 1. So we are so grateful, and I know I learned so much from your presentation, as I'm sure many of our audience members did as well. So we thank you again for joining us, and we hope you have a great rest of your weekend. And if you have any questions after the conference about what we're doing to keep updated on all things NPHC, please reach out to me or our team. And thank you so much for joining us.
Thank you. You guys are great. It's a great conference. I'm really impressed. Thanks. Thanks for having me.
Thank you. Have a great day.
Thanks. Bye.
All right, everybody. We are going to transition into the next session of our National Pre-Health Conference Day 1. It is coming to a close, but we have an exciting special event to close this Day 1 with, our Research Expo.
Yes, we are very excited, and I also wanted to thank Dr. Shapiro for her presentation. I really enjoyed being able to learn about her schedule because it's really informative as students thinking about the different careers and specialties in medicine that we want to have to know what the schedules will look like. So now, while we wait for our student presenters to join the meeting, I will share the slide with the information of our speakers, and we will be back in about 14 minutes. So please join us to start the Research Expo and take a break, stretch a little bit, maybe take some water, and we'll see you really soon.